معنا إن شاء الله موضوع البيدياتريكس من هون لنهاية الكورس. أولا نعطي تقريبا نوع من الانترودكشن عن البيدياتريكس و what are the changes or how they are different from adults and other patient populations. Then we will talk about the most common pediatric diseases. There are a lot of pediatric diseases, but we're going to be focusing on the most common ones, so you know the pharmacotherapy for each of these diseases in children. So I will start by giving just a quick outline of the topics that we're going to be covering in this part. And this chapter available in the book as well, and I can post it on e-learning. So we will start today our discussion by a brief introduction about the pharmacotherapy of pediatrics. Then we will talk about the growth and development in those children, and we will know the classification of these groups. Sometimes we say neonates, infants, children. So we want to know the cut-off age for each group or subgroup of this population. We will be focusing on some of the pharmacokinetic differences between the different ages in pediatrics and how they are different from adults. We will also be talking next time about the pharmacodynamic differences, the medication dosing in children, and how can we prevent medication errors in children. And we will conclude next lecture by focusing on increasing pediatric medication information. So let's get started with the quick introduction about pediatric pharmacotherapy. And the introduction is we need to know that there is some variation in the body weight of children, of newborn infants, what you want to call it. Patients range in age from premature neonates, those who are preemies or they are born before full term, to adolescents, and can vary in body weight also. So if you look at the ratio of body weight change, so it might reach about 100-fold, from 0.5 kg, just half a kilogram for a premature neonate, to a 50 kg in a child who is 16 years old. So between 16 and 0.5 kg, you might see about 100-fold difference sometimes, and this is just the mean. And further complicating the care of children is the relative lack of information on a drug dosing and monitoring. So in adults, when we develop drugs, we perform clinical trials in adults, and you will have plenty of adults who are volunteering in these clinical trials. However, in children, not too many people, they volunteer their children to participate or take part in those clinical trials. As a result, we have a relative lack of information about the appropriate dosing. What would be the most appropriate dose for that patient population? And the monitoring of those patients also. Let's say in phase 4 trials, we don't normally have plenty of information to support our knowledge about this patient population. Around 60% of all prescriptions written by pediatricians are for off-label uses. Why? Because we don't have enough information about the correct dosing. Is this a drug safe in children or not? That's the question. So in a study, they found approximately 60% of all prescriptions written by physicians, they are just off-label, which means they are not mentioned in the leaflet as an approved indication for that drug. Therefore, they're just using them as off-label. I'll give you a current example right now, hydroxychloroquine. I think most of you just heard in the news that hydroxychloroquine, it's an anti-malaria drug, it's or it's used in rheumatoid arthritis. It's been known for a long, long time ago, maybe for about 3 decades or more. But now they started using this drug in combination with Zithromax or azithromycin to fight against the coronavirus. This is an off-label use because it's not mentioned in the leaflet of the drug. So again, that's an off-label they found by incidence or by experience that might work. That's why they are using this drug in this situation. So dosing and monitoring information for off-label uses, we have also limited resources. Again, I will go back to the same example, hydroxychloroquine. We know the dose for malaria. We know the dose for rheumatoid arthritis. But what's going to be the dose for antiviral activity if it works? Again, we can't claim that's really effective in coronavirus, for example, until we have strong evidence. We have enough data from clinical trials. We test it in people, and we can claim that this drug is effective, and this is the dosage regimen. We need to know the dosing, and we need to monitor. And when we say the monitor, you need to monitor for two things: efficacy of the drug and the safety of the drug. Do we have side effects? And do we have a risk-benefit balance between the two? And the other thing is also in children is the PK and PD differences between children and adults. Of course, there are differences in the pharmacokinetics and pharmacodynamics between children and adults, and we need to study how these differences impact the efficacy of the drug and the safety of the drug. So let's get started with children. Normally they undergo considerable physiologic changes between birth and adulthood. So these are physiologic changes, normal developmental processes that occur in all children. Exceptions are there if they have retardation to growth or they have growth problems. So there are again PK and PD, pharmacokinetic and pharmacodynamic differences between children and adults. So can we say that growth in children is predictable to follow a linear fashion? In fact, it is not, because there are some exceptions, but rather that growth occurs in periodic bursts. It's kind of in bursts with additional variation caused by differences. People are different in terms of their genetic predisposition. They are different by their nutritional intake. So you will see some areas of the world, they have poverty, they have malnutrition, they have low access to food. On the other hand, we have people, they have full access to food and they might suffer from obesity. If you compare two children of the same age, one is obese or overweight and one is underweight, pharmacokinetics are different. We will see in a minute how they are different. The third thing is the environment also. So genetics and environment, including also nutritional intake. And there is one branch, in fact, in pharmacology, it's called developmental pharmacology, which studies the impact of a growth and development on the two main parts of pharmacology, the pharmacokinetics and pharmacodynamics. So what are the ages? We hear a lot, the neonate, infant, child, adolescents, term neonate, premature neonate. So we need to understand or know the age classification. So if I tell you a premature neonate, it's a child or baby who was born at more than 36 weeks gestational age. Just before that gestational age. And a term neonate, that's a full term. The cutoff point, 36 months after pregnancy or gestational age, that's a full term. A neonate is just who was born today or birth until 1 month of age. We call him a neonate. Infant is more than a month and up to 1 year of age, and a child 1 to 11 years, and adolescent 12 to 16 years of age. So again, we have premature neonate, did not reach 36, term neonate, neonate, infant, child, and adolescents. So everybody who is about 36 weeks all the way up to 16 years, we will consider them pediatric patient population. Now, all aspects of pharmacology, you know, the pharmacokinetics and pharmacodynamics, and now we're going to be talking about the pharmacokinetic part of pharmacology. And you know the 4 key processes in pharmacokinetics, namely absorption, distribution, metabolism, and elimination of the drugs. They are affected by growth and physical maturation of the child. Beginning during gestation or during a pregnancy, there will be changes, and ending in adulthood, about 16 years old. So when we talk about drug absorption, we will be focusing on 4 things: the oral route of administration, the oral absorption, or absorption after oral administration of a drug. We will talk about intramuscular drug absorption. Third, we will be talking about transdermal drug absorption and rectal drug absorption. The next branch of pharmacokinetics is distribution. And distribution, 3 main factors or parts we will be focusing on is the body water in that patient, how much water that body contains, because it's affecting the distribution of the drug, whether the drug is a water soluble or a fats or a lipid soluble drug. Number 2, body fat content. And number 3, protein binding or plasma protein binding of the drug. Is the drug in concern highly bound to plasma proteins or negligible? That's different also, because protein content in plasma is different in this patient population. The third one is metabolism. We will be talking about it next time. We will talk about phase 1 reactions and phase 2 reactions. The phase 1 normally is the oxidation reduction reactions and hydrolysis, and the phase 2 is the conjugation. As you know, these are 2 phases for drug metabolism, mainly in the liver, in order to make the drug more polar so it can be excreted. And the 4th branch of pharmacokinetics is elimination. We will be talking about glomerular filtration in the kidney and tubular secretion as well. So let's get started with oral absorption. What are the changes that are different in pediatric population? The first one that you should hit our minds is the gastric fluid volume. So when the baby got born, they have a decreased gastric acid production. Therefore, we would expect that to affect oral absorption of the drugs. Number 2, transport of bile acids. Bile acids are secreted from the liver, and they go into the gastrointestinal lumen. In addition to pancreatic enzyme production, they are also reduced in pediatrics. So they will change absorption of pH-sensitive drugs and reducing enterohepatic circulation. Enterohepatic, the drug will be going to the liver instead of other tissues. So from the intestine going to the liver, then it will be secreted again. It's the enterohepatic circulation. So 2 things here, or 3 things: the gastric fluid volume decreased, the transport of bile acids into the GI lumen decreased, pancreatic enzymes secreted from pancreas, they also decreased. And these enzymes, they will affect the rate of absorption or the extent of absorption of certain drugs in the GI tract in babies or children. Amylase activity is also minimal. Gastric lipase has greater percentage of fat absorption during early life. So neonates, they're relatively considered to have sterile gastrointestinal tract. Normally after that, or in adults or other age population groups, they have normal flora, normal bacteria colonization in the GI tract. These, sometimes we rely on them for activation or degradation of certain drugs. But the newborn, when they are newly born, they have kind of sterile gastro. They don't have that normal flora for the first part of that age or the early after birth. So that will affect certain activation or degradation of certain drugs, if they are dependent, of course, on normal flora. Looking at the gastrointestinal tract again, we have the gastric emptying time got delayed. We have prolonged intestinal transit time. So by doing so, it means the transit time will have a better absorption in this situation. Reduce splanchnic blood flow. The blood flow to that area also is lower. So if certain drugs, they depend on the passive diffusion processes, that will be impacted. So you would expect to have a lower absorption of that drug. So there is no general rule. It depends on the physicochemical properties of the drug and how the body of the pediatric patient will handle that. So again, we have to look at each drug individually to see the physicochemical properties. Is it highly acidic, weak acid, weak base? Is it lipid soluble? It's water soluble? Is that drug gets transferred by passive diffusion or not? So we need to ask ourselves these questions so we can decide what is the effect of oral absorption in this patient population. Again, we have lower levels of metabolic enzyme activity in the intestine, may reduce first pass metabolism. The main first pass metabolism normally in the liver. However, we have some little activity for certain enzymes in the GI tract, in the intestine. So this way, in pediatric patients, we have lower level of these metabolic enzymes. As a consequence, drug concentration will increase in this patient population when they are newly born. So this is about oral absorption of a drug. Now let's move to the next one, is the intramuscular injection of a drug. What happens for drug absorption after intramuscular injection? So there is a delay in time to reach peak serum concentrations in neonates. As you know, intramuscular is slower than intravenous, for example, but it's faster than oral. So in children, there is a delay in time to reach the peak serum concentration, what we call it Cmax. So Cmax or Tmax is the time needed to reach Cmax. The Tmax is going to be longer in this patient population. The reasons for that, we have a small muscle size. When the baby just got born, we have a small muscle size compared with an adult, for example. We have weaker muscle contractions, which means the movement of the muscle is slower, then absorption is slower, and an immature vasculature in that muscle. So it takes time for vasculature, for blood vessels to develop and get mature in that baby. It could be disadvantage for certain drugs. The reason for that, when rapid absorption is needed, When you inject the drug intramuscular and you need a rapid action, then this is not a good way. Therefore, it's kind of disadvantage. But for certain other drugs, it could be an advantage, in fact, because if you give it in the muscle and the absorption is kind of delayed, this is a form of a depot-like effect, as if you are giving a depot. A depot is releasing the drug continuously in a slow fashion. So this way, it could be considered advantageous. Subcutaneous injection, also, it has a lower percentage of body fat in neonates. Therefore, it depends again on the composition or the properties of the drug. If it's a lipid soluble, then it would cross easily and get absorbed fastly in subcutaneous injection, and vice versa. So the delay seen in absorption with intramuscular and subcutaneous administration becomes negligible after the first month of life. What does this mean? It means it's really critical for neonates the first month of life. This is significant delay in a drug absorption after intramuscular and subcutaneous injection. But after 1 month of age, you're fine. So it becomes negligible after that age. Therefore, it's important to know what is the age of the baby in concern. So you need to look at the age of the baby. And by the way, they have done some studies and they noticed a lot of medication errors in this patient population. Either it could be an underdose or overdose because they're just trying to ignore the age factor for those babies. Are they younger than 1 month or older than 1 month? The next route of administration is the transdermal, or sometimes, or some books or references, they call it percutaneous drug administration or absorption. So greater drug absorption in children, transdermal when you apply something on the skin for children. This is kind of, it might cause significant toxicity, especially in babies. The reason for that, let's focus on these factors. Look at these 4 factors. They have a greater skin to body surface area ratio. It's around 3 times the adult. So they have a wider surface area, and this is known. If you have a wider surface area, when you apply something topically, then you will have a greater absorption. Number 2, they have a thinner stratum corneum. That layer of the skin is very thin. Then you expect absorption to, when you apply topically, to penetrate in more quantities or faster or easier. Number 3, they have better epidermis hydration. So this would lead to, especially if you have water-soluble drugs, to cross, and they will have a greater perfusion. There are 3 examples that I would like to mention here. The first one of the soaps they normally use in children to bath the child, especially the newborns, they have a substance called hexachlorophene. This hexachlorophene, normally it's the detergent available in that soap. If you apply it in newborns in larger quantities or more often, you will have systemic absorption. The problem, it's contraindicated, especially if the child has seizures. They might cause seizures in that children. Number 2, you all know povidone iodine. It's kind of a topical disinfectant, especially if they do some surgery on pediatrics. They might use povidone iodine in large quantities. So this, again, this drug, it might cause, if you apply it on a larger or a large surface area in babies, it might lead to neonatal thyroidal dysfunction because of the iodine content. Number 3 example is the diaper rash products. Diaper rash products, when you work in the pharmacy, never give hydrocortisone or corticosteroid topical applications for diaper rash. It's a very pretty common problem in children, especially at the younger ages. So if they apply it continuously, even for 2 weeks, they keep applying this for 2 weeks, they will have suppression of the hypothalamus pituitary adrenal axis. So you can imagine the effect of this topical cream, hydrocortisone, on systemic action, on systemic suppression of the hypothalamus pituitary adrenal axis. So never use for larger quantities and for longer period of time. So the transdermal is the third route of administration, drug absorption. Here, widely used as topical anesthetics sometimes. We use it in children sometimes as a topical anesthetic for infants and children before, let's say, they need to take a blood sample from the vein. So before venipuncture, they sometimes use topical anesthetic in children, which is okay. Sometimes they use IV catheter. So if they need to replace it because it stings and it's causing pain to the infant or the child. In male babies, sometimes they use them in circumcision. So that surgery also needs some local anesthesia, which is okay to use. One of the most commonly used topical anesthetics in this case is EMLA. EMLA is 4% lidocaine and prilocaine. As you see in the picture, this is a local topical anesthetic. Sometimes they use it for these indications as we just mentioned. They are safe and effective. And the reason for that, because they have a low concentration of the active ingredient, especially if they are given for only a very limited period of time. For a short period of time, the contact with the skin is going to be just for 30 minutes or 60 minutes to prevent excessive systemic absorption. When applied to intact skin, not to broken skin or burns or wounds, that's a different story. Other transdermal medications generally should be avoided or used with a precaution for only limited periods of time. So we need to monitor for that use. Some of them, they are contraindicated or they are avoided, and some of them we can give them, but with a precaution. So after the first year of life, transdermal application becomes a more useful route of administration for several medications. So the criticality is, in fact, in babies less than 1 year when we talk about transdermal or percutaneous drug absorption. Examples for a little bit older adults, children more than 1 year, methylphenidate and clonidine patches. These are transdermal therapeutic systems. They use them in the treatment of attention deficit hyperactivity disorder or ADHD in school-age children, 6, 7, 8 years, etc. Another example is the use of lidocaine and fentanyl patches. They are used for treatment of pain in older children and adolescents, especially if they have severe pain. So these can be used as topical or transdermal patches. The next one would be rectal absorption of drugs. Rectal absorption, most drugs are well absorbed via rectal route, and strong rectal contractions, sometimes there are certain conditions work against this route, like strong rectal contractions in infants, inability to return the suppository for length of time, for a period of time to achieve optimal absorption because of that contraction. So it's not going to be fully absorbed as we wish, but still it can be used. And I think most of you, they know paracetamol suppository they give in infant and children. So some other drugs, they are available as gels or liquids. They don't require the advantage of these preparations or dosage forms. They don't require an extended time for dissolution, and they will consequently have a better option. So example of this is the diazepam rectal gel. It's used in children with seizure disorder. So as you see in the picture, this is a diazepam rectal gel. It can be filled through the syringe-like without a needle, and they can push it in the rectum and give it to the children, especially if they have certain types of seizures, of course. So altering the pattern of distribution and extent of a drug penetration. So we talked so far about the first component of pharmacokinetics, the absorption. We will move now to distribution of the drug. So imagine a drug has been given via oral route. It went to the GI tract, get absorbed. The next step is to get distributed in the body. So that distribution depends on the organ size. We talk about lungs, about heart, about brain, about liver, about GI tract, bones, any organ that you would like. And you need to look at the body water content. How much water do they have? What about fat stores in the pediatric body? What about plasma protein concentrations? Think about the acid-base balance. Think about the cardiac output and tissue perfusion, because all of these factors would affect the extent of a drug penetration and distribution to the different organs. For example, drug distribution in neonates is high in the nervous system. Central nervous system, it receives a high concentration of a drug. Therefore, we need to be careful about those drugs which can penetrate blood-brain barrier, especially in this patient population. So let's look and compare the brain versus adult. So the brain normally serves as a much larger potential compartment for a drug distribution. So it's a large component. Some drugs, especially lipophilic drugs that cross the blood-brain barrier, they will go to the brain, get distributed there. So on the right-hand side, this is an infant brain. Up to 10 to 12% of the weight of an infant. So if we take the relative weight of a brain in infant and compare it to an adult, we as adults, the brain constitutes only 2% of our total body weight, while in children it's about 10 to 12. The percentage also in infants of systemic blood flow that reaches the cerebral vasculature is greater, so they have better perfusion to brain tissue or cells. Greater passive diffusion of drugs. So three factors here: the size of the brain or the weight of the brain relative to their body weight is higher, blood flow to the brain is much better or greater, and they will have more passive diffusion of drugs. So collectively, all of these factors, if we take them together, then we will end up with a higher drug concentration within the central nervous system compared with older adults and children. So this might carry also, again, a benefit and risk, or advantage and disadvantage. The benefit, when we need a drug to be distributed into the central nervous system. Think about meningitis. If the child or the neonate or infant, he has meningitis, we need the drug to reach the brain in a considerable concentration to fight against meningitis. Think about other drugs that we don't need a central effect in the central nervous system, but they reach there. This is a disadvantage because it reaches in a higher concentration as compared to adults or older children. The next factor is think about body water content in the body. So if you look even at the picture here, you see in blue How much? Let's say in humans, it's less than maybe 50 to 60%, whether it's a male or a female. But this infant, you could see maybe 80 or 85% of their body is water. So there is a decrease in total body water content as we increase with age. So look at the premature newborn, almost 85% of their body weight is water. It will decrease a little bit as they become a term newborn or full term newborn. It will even decrease to 60 or 65 in a 1 year old. Then after the age 1 year of age, it will decline to 50 to 60%. So think about this: newborn or premature newborn, new term or full term newborn, 1 year and above 1 year. So as we grow older, the percentage of water is decreasing. So based on that fact, we will have much greater distribution of highly water soluble drugs. For example, aminoglycosides, they are antibacterial agents, and linezolid or linezolid, they have a much greater distribution in water soluble drugs. On the other hand, we will have reduced accumulation of highly lipid soluble drugs. And because they have more water content, then we will have reduced accumulation of highly lipid soluble drugs. Examples of these are amphotericin B, amiodarone, benzodiazepines, or digoxin. These are highly lipid soluble drugs. So typically we need to adjust the dose based on this water content fact during infancy. So we'll have to see the physical-chemical properties of that drug. Is it water soluble or lipid soluble? Then we will decide about the appropriate dosing. The next factor is how much fat do they have in their body. So if you look, fat is kind of opposite to the water content. As we grow in age, we will have more fat. So look at the premature neonates, they have 1 to 2% of their body weight as fat. Term infant will have closer to 10 to 15% of body fat. And 1 year and older, it's about a 20 to 25% of body weight like fat. So as we grow older, we will have more fatty content. So again, if the children or the child is following normal growth patterns, they normally have relatively little change in their body fat percentage between the second year and the onset of puberty. So that's change is kind of very little change. The increasing rate of childhood obesity would be the problem. So if you see this picture, this baby has already obesity, which is abnormal. That's called childhood obesity. It raised general concern about the efficacy and safety of current weight-based dosing strategies, which means if you give drug X dose, it's calculated per body weight, it might be misleading in this patient population. Because think about the body composition, it's abnormal. The percentage of fat is not normal in their body. So your assumption is going to be incorrect if you just calculate it by body weight. So you have to take into consideration how much fat do they have by looking also at the physical-chemical properties of the drug. Is it highly lipid soluble or highly water soluble? Then you need to give the right dose. And again, they also have done some studies in this respect, and they found a lot of medication errors in prescribing medications for obese children in this patient population. The next topic in pharmacokinetics is protein binding. And plasma protein binding of drugs, it gets reduced in infants as a result of the proteins that are circulating in their plasma. Specifically, we're talking about albumin and alpha-1 acid glycoprotein And the next step is, or the next factor is decreasing binding activity, affinity. So these drugs, they have a lower binding affinity, and they have this patient's population also, they have decreased circulating levels of these proteins that will bind the drugs. So drugs with a high binding affinity for albumin during the neonatal period, there will be competition, of course, with bilirubin for binding sites. Both of them, the drug has high affinity, let's say, for binding these proteins, and their bodies, they have also bilirubin. Especially in the Middle East, we'll have a lot of bilirubin, especially at birth. It's normally higher than normal. So that will lead to increase in the unbound bilirubin, or kernicterus, we call it, which has neurologic consequences. It might lead to damage because of the deposition of bilirubin in the brain. So the drug, because it has higher affinity to bind these proteins, it will compete with bilirubin. Then bilirubin is free in the plasma. It will ultimately go and reach the brain. It will accumulate in the brain, leading to kernicterus, and that's primarily in basal ganglia, will lead maybe to brain tissue damage. So that's really very serious. So examples of some drugs that are present in a greater unbound fraction or concentration in neonates than in adults. So these examples that you see in the table on the right, they have higher unbound fraction or concentration in neonates. They don't have higher affinity, so they will be circulating freely. And this is the fraction of the drug that's going to show the effect. Then you will have a toxic level in this case of that drug. So we'll have alfentanil, ampicillin, ceftriaxone, cefuroxime, diazepam, digoxin, lidocaine, ketamine, morphine, nafcillin, penicillin G, phenobarbital, phenytoin, propranolol, salicylates, sulfonamides, thioflin, and valproic acid. So all of these medications, they have a greater unbound concentration in neonates as compared to adults. So that's the last slide in today's lecture. Next time, inshallah, we will continue with drug metabolism and elimination of drugs. And we will see if we can start with the other part also. So I will have 7 minutes now for any questions, if you guys have any questions. No questions?